Good afternoon and welcome to Lyon for the ESOC 2022 conference, and we have the wonderful morning session of the large clinical trials. My name is Daniel Strbian from Helsinki, and together with Professor Joanna Wardlow, we are going to lead the discussion with Professor Urs from Basel and Professor Georgios Tsivougolis from Athens. We just heard 9 trials presented in 2 hours, and so we actually have quite a lot to discuss. So why don't we start with asking a question to Professor Urs Fischer from Basel. Now, tenecteplase debate, tenecteplase versus alteplase, was ongoing for many years. Now, we know we've been discussing the doses and the time window. So what are your first impressions? We heard 3 different tenecteplase trials today. So please, Urs.
So thank you very much for inviting me. I think it was really a very interesting morning today, and I think we really had great sessions. And I think we have some clear answers now today. And I think the NORTEST trial gives us a clear answer that tenecteplase 0.4 is dangerous. They had to stop the trial. They had an increase in hemorrhage rates. So I think this is a very important message. So I think we will not go on with tenecteplase 0.4 in the future. 0.25 is very interesting. The ACT trial was a very promising results, and they could show non-inferiority. So I think we are shifting now really the landscape in the direction that tenecteplase is non-inferior to alteplase. However, I think also with Professor Tsivougolis, we are going to discuss a little bit this is not the first trial comparing alteplase and tenecteplase. So I think we now have to look at the differences, also considering the previous trial, especially NORTEST one.
Thank you, Urs. And I would have a question for Professor Tsivougolis. So now, actually, according to the secondary analysis, even in today's trial, we saw that maybe there was a benefit of tenecteplase for the patients who have a large vessel occlusion, which is basically in line with the previous trials. Would you like to maybe comment?
Yeah, so there was a non-significant trend towards better outcomes in large vessel occlusion patients in ACT trial, which was very important. I think they recruited about 25% of their patients with large vessel occlusion, and the absolute benefit increase was around 5.5, 5.6%. And we have conducted a meta-analysis of 4 trials that approximated 430 patients that also showed that in large vessel occlusion, tenecteplase is superior to alteplase in terms of efficacy. This is a modified Rankin scale score of 0 to 2, successful reperfusion rate, and early neurological improvement. So I think this is a very important message from the biggest to date phase 3 tenecteplase trial with a 0.25 milligram per kilogram dose, because to date this was the first phase 3 trial. So I think this is very promising.
Thank you. And one final question about tenecteplase from me, and then I think maybe Joanna can go on. So, well, we know that if tenecteplase is non-inferior or better than alteplase, so does it make any sense to test this in the pre-hospital setting, in the ambulance? What do you think, Urs?
I mean, we also have seen the pre-hospital trial today, and also, I mean, the design, we can have a long debate on surrogate trials, and at the end of the day, we as clinicians, we want to know whether it changed the fate of our patients, whether it increased hemorrhage rates. Nevertheless, I think also these results are quite promising, because I think one of the big advantages of tenecteplase is much easier to give to the patient, we have the effect of the drug immediately, whereas with alteplase you're giving it over 1 hour. And I think at the end of the day, this is probably the driver or the main difference of these 2 drugs. Yeah. Just simply the application, 1 single shot, and then the drug is in. Whereas with alteplase, it takes you some time, you know, to give the first shot, and then you have to start the perfusion over 1 hour. And I think at the end of the day of practicability, this is probably key.
Many thanks, both of you. Maybe, Joanna, if you would like to go on?
Well, I just had another comment, which was, I thought it was very interesting in the Melbourne Mobile Stroke Unit tenecteplase trial, the TASTE-A trial, that essentially what was what the mobile unit and the tenecteplase was facilitating was the bolus. By the time the patient got to hospital, there was already some evidence of beginning to open the arteries, whereas alteplase was still finishing its infusion. So even from the point of view of maybe getting that effect earlier, there would potentially be a benefit in some situations. I was watching the questions as they came in on the stream, and there were questions about what are the relative costs of the two drugs? What are the implications for different income countries? I don't know whether you have some thoughts about that, because this is where we've got enough choice. You can start to divide out things according to what's most practical in different settings.
So there are some cost-effectiveness trials conducted in Australia and New Zealand, because in New Zealand, in real-world evidence settings, in many centers, they have switched the treatment of all acute ischemic stroke patients from alteplase to tenecteplase, showing that tenecteplase actually is more cost-effective than alteplase because it averts more thrombectomies. And in countries where you don't have this availability, like in Greece, and we have tested it also in our settings, there was an absolute increase of 12% in the thrombectomies that were averted thanks to tenecteplase, and I think this will be the biggest driver for cost effectiveness. With regard to the price of the drug, the price is identical, at least in Greece. I don't know if there are any price differences in Switzerland.
No major difference, but I think, coming back to your question, I think the availability of the drug is currently an issue. We all know that there is a shortage of tenecteplase, and so the drug is not available everywhere, and I think that will be one of the major challenges in the future. And eventually there will also biosimilars coming up, but they also have then to prove that they are equally effective, that's the real drug. I think that is also something which has to be tested in the near future.
Yes, and something that our colleagues need to understand, tenecteplase right now is off-label for acute ischemic stroke. So there may be some medical-legal issues if we start using tenecteplase like water. This is number one. Second, there is an issue of dosing. So the instruction of tenecteplase is at a dosage of 0.5 milligram per kilogram. This is for acute MI. So if somebody takes the dosing instructions for MI and he uses this dose for acute ischemic stroke, then he will most certainly cause bleeding, as was shown in the Norwegian trial. So we need to understand the dose correctly and not just read the dosing instructions, because these are for MI, for tenecteplase right now.
Okay. Sorry.
Yeah. Thank you. And actually, you touched the very important questions of the global shortage of actually both tenecteplase and alteplase, which will last maybe at least for 2 years. We'll see. Would you like to ask another question about tenecteplase, Joanna?
No, I actually wanted to move on to some of the other information that we heard. So we heard about what you might regard as several procedural things about early diagnosis in the ambulance, which was a really important study, and then also about tracheostomy and sedation. And then we also heard about two approaches to secondary prevention. So we've heard a lot of material, plus basilar thrombosis. So I just wanted to kind of comment on the Norwegian paramedic study, ParaSnap, which demonstrated a number of things, including speeding up some of the processes getting through hospital. And although I think there may be slight disappointment in not meeting its primary endpoint, actually it's done a lot of other very useful things. So I thought that was very groundbreaking, and perhaps we can move towards having a more unified approach to early assessment in the ambulance. That means that paramedics, etc., can be more involved, and this will help deliver patients to hospital more quickly. I don't know what your thoughts were.
Yeah, I fully agree. I think it's first of all, I really like the concept, doing trials together with in the ambulance. I think that is fantastic. I think one of the burning questions is always: is it possible to predict a stroke by clinical examination? And we know it is impossible. And it's also the question whether we really can predict large vessel occlusion. That's also something which is a challenge. So I think we need to move in the direction of mobile stroke units where we can have fast imaging in the ambulance, and also looking whether the patient has a large vessel occlusion. I think that is key. I don't know what you think.
Yeah, I fully agree, and I would like to congratulate the ESOC organizing committee for inviting paramedics.
Yes.
I have been attending the ISC and the ESC and the ESOC for more than 20 years. This is the first time I'm seeing a paramedic presenting in a large clinical session, so I think this was a very welcome novelty, and they're paramount for treating effectively our patients.
Thank you, Georgios. Maybe just a comment that Urs has actually written several years ago an article which name was Prediction of Stroke Mission Impossible. So maybe this is something that you can read. But now maybe I will ask a second question, and I will maybe skip to Atticus trial. I will ask Professor Sivgolis that, well, one of the maybe major findings was that because there was mandatory monitoring of atrial fibrillation, they found out that actually there was 28% of the atrial fibrillation, and then it was allowed by the protocol to skip from ASA to apixaban. So what are your feelings about the results of the trial?
So this was atrial fibrillation detected by implantable cardiac monitoring. That was not clinical atrial fibrillation. Yes. And we have conducted a meta-analysis of different implantable cardiac monitoring studies, and we have shown that in ESOC, the 1-year rate of detection with AF with implantable cardiac monitors was 23%, very close to what was reported in Atticus. So I think if you use the implantable cardiac monitor, you're going to detect more atrial fibrillation. What I think Atticus showed is that ESOC, for me, it's dead. It's not on the, I'm sorry for being politically incorrect. I'm expressing my own personal belief. I think it was a very coined and a very sophisticated term, but it was not clinically driven. It was a theoretical term, and the clinical trials show that there is no utility. And we will wait for Arcadia and the atrial cardiopathy concept, but I have seen no evidence that based on this enriched ESOC definition, we should substitute aspirin with NOACs.
Yes. Yeah, I fully agree, and I think I also have to admit that from my perspective, this concept of ESOC, I have never liked that. I mean, I think at the end of the day, we have to search the etiology of our stroke. We just don't have to say, well, it's coming from somebody or somewhere in the heart. I think the future direction probably could be right that we look at biomarkers which could predict the recurrence rate. So we know that we now have biomarkers as MR-ProNP, which eventually could guide us which patient is going to develop an atrial fibrillation. And there are ongoing trials such as the Moses trial, and I really encourage people to randomize patients into these trials because that's the next burning question in that perspective.
Yeah, that's true. Thank you. Maybe Joanna?
Yeah, well, perhaps we could just move on briefly in the last few minutes because we heard some other things. We heard about different ways of administering tracheostomy in people who require ventilation after severe stroke, and also in procedural sedation versus general anesthesia for thrombectomy. And both of those seem to say, well, actually, you've got a bit of a choice here, depending perhaps on your patient population. But it doesn't necessarily mean that you have to change practice overnight. So I actually thought those were really helpful. I don't know what your thoughts were.
I think what is most important, both trials showed that there were no safety concerns with either the one or the other approach. Of course, there was no difference in terms of efficacy. So I think that what is more important is that each individual center should develop its own protocol, be very familiar with this protocol and adhere to this protocol. And I think these are very good pragmatical trials that really help us in performing our own protocols in our own terms.
Yeah, and I agree. And I think also in clinical practice, I mean, there are some patients you just simply have to ventilate during the intervention because they cannot, lie on a table. They're moving constantly. So they have loss of Glasgow Coma Scale of 4 to 5. So you have to ventilate them. So it gives us some kind of indication. Both are probably equally effective.
Yeah, thank you. Yeah. And maybe we have some seconds to ask about something about the basilar atrial occlusion trial. So, well, maybe a bit we can say in line with the results of the BASICS trial, where actually there was maybe in the secondary analysis a benefit for the patients who presented with NIH more than 10. So basically in this today trial, it was the inclusion criteria. So what would you think, maybe now first Urs and then Georgios, is NIH playing actually a role in the selection of patients for the treatment?
That's a very tough question. Honestly, I think on a long run, probably it will not be the NIH which is the main driver. I think the main driver is the site of the vessel occlusion. Yes. I think that from my perspective is much more important. Yes. But honestly, I was not surprised by the results. We all know the shortcomings of the BASIC trial, randomization over 8 years, and we know that some sites, they just have simply selected the patients, and only patients have been randomized where there was clinical equipoise. equipoise, or where the physician thought that is clinical equipoise. I mean, we have done thrombectomy in patients with basilar artery occlusion now for 20 years, and therefore we would have been extremely reluctant to randomize these patients, because we just simply have seen in retrospective case control studies that it works. So for us, it would have been an ethical problem to sacrifice these patients for such a trial. But I know that the trials are extremely important to answer this question, but I think now we have some evidence. Nevertheless, there are some caveats, because I think this is an Asian population. You cannot say that Asian Caucasians are similar. I think that's something which we have to consider. Nevertheless, it's a proof of concept, and I think it's going the right direction.
Thank you. And maybe we have to move to the final closing remarks, maybe by Joanna.
Okay, well, listen, thank you so much for coming along and discussing the trials that we've just heard. The material is also available online. You can also see the questions that were submitted, and we can look forward to another 2 plenaries, hopefully, of such also excellent material. So thank you very much for coming along for this discussion.